All right. Jens, it's great to have you on the podcast, on the Justice Podcast. Before we jump in to the meat of the subject, I've got a quick question for you. And it's a common question that I think everybody hears at some point or another. One, do you like pizza? And then two, favorite flavor pizza?
Oh, I didn't realize this was going to be a controversial podcast. Um, yeah, yeah. I always liked all of the different varieties of pizza growing up. But my daughter is 13 years old, and about 3 years ago, she decided when we entered a meat market on the spot, she's a vegetarian. And ever since that, it's influenced our whole household's diet. And I'm not a vegetarian. So when I get the opportunity for pizza with some sort of meat on it, makes me very happy.
Wow. Yeah, I get that's like a life-changing experience right there. That's a pretty big deal. But we want to talk about more than just pizza today. We want to talk about healthcare, the healthcare system. I don't know that we're going to solve every single problem in this, half an hour span. But maybe we can explore some of the areas where you have experience. Everybody wants to talk, but nobody wants to listen. So here's my petition. Instead of division, let's make our mission to change the system. Learn how the world works. Learn how we can act. Welcome, everybody, to the Justice Podcast. Could you tell the audience just a little bit about your background and why you're qualified to speak to some of these issues?
Yeah, sure. So I am a benefit advisor and management consultant based out of State College, Pennsylvania, and I got into the insurance business, 1998. And I discovered this section of it dealing with health insurance and employee benefit plans for employers about 2 years later and just fell in love with it. So during the course of my career, I've had the opportunity to work with small and medium-sized businesses, to work with large self-funded employers, a lot of healthcare clients, including hospitals, physician practices, advanced imaging centers, surgery centers, et cetera. And I was the president of a benefit consulting shop that I sold to a global broker in New York, where I had some leadership responsibilities across a couple of states for about 4 years. So I've got a lot of experience touching healthcare as a client, having them as clients, dealing with this whole place that health insurance fits into that. And then I've also got this one additional interesting role in my professional life right now, which is I do some consulting for a biotech company called Apos Health, who provides a non-surgical alternative to various things like osteoarthritis of the knee as a way to delay or eliminate the need for knee surgery. So across all these different experiences, I think I have a little bit of point of view on the American healthcare space.
So we definitely want to dive into Apos later in the conversation. But first, in your experience of providing benefit services, was there any deal that was particularly challenging or maybe even rewarding because of the work that it required?
Well, that's a really interesting question. So you mean in terms of like client acquisition and the project of getting the client? Yeah. So the way I always think about client acquisition in consulting is there are three necessary ingredients that result in something happening. If you don't have all three, inevitably nothing happens. And those three things are: number one, relationship with the decision makers at the client. In other words, trust. If you can't build that trust, nothing's going to happen. And number two, you've got to have a solution to a problem that the customer understands. And then number three, generally there's got to be some sort of a catalyst. And that catalyst can be the retirement of another advisor, the emergence of some other business issue, a merger or acquisition of former contract for an advisor that's in force. But without some catalyst, even if you're solving a problem, you have a relationship, inertia is a powerful thing in business. So interesting. I'd say that the issues that have been the most interesting amongst all of them, aside from corporate development, mergers and acquisitions, and relationship issues, which are always present, it's probably all the healthcare clients. And the reason I say that is if you think about, I wouldn't say just one, but I've worked with a lot of different hospitals, a lot of physician practices, ambulatory surgery centers, a large grocery store chain that included pharmacy capabilities. And in every one of these cases, you have multiple dynamics around, for example, in hospitals, they have their own pharmacies, their employees are also their patients, they're also customers at their own pharmacies. And then there's this government financing thing for indigent populations called 340B, which is hugely consequential to a lot of hospitals around the country. And when you tie all of it together, it turns into really kind of interesting and dynamic and complicated fact patterns that are sort of fun to work through, frankly.
Yeah, I could see how that kind of self-consuming ecosystem would be really complicated.
Yeah.
So maybe I don't even need to ask this question, but why do you feel like an advisor or a broker is necessary when people are selecting healthcare?
Oh, okay. So we bucket that into three things. At the top of the list is providing advice. Anytime a customer is thinking about their path forward, there is some value in having an advisor who has some additional context and knowledge to identify the possible paths forward, the pros and cons of them relative to one another, and then to isolate the choice that's best at this time. And then once that's done, then there's an important role for the advisor to play in executing that strategy, because a great game plan on the shelf isn't of much value to anybody. You've got to get things done, and the advisor takes a role in that in terms of managing timelines and coordinating communication and deploying certain aspects of any project. Finally, there's a role that advisors play in advocacy, whether it's relative to like internal stakeholders and customers at clients relative to others, helping HR and finance communicate something to the CEO or COO at the company. There's also advocacy relative to vendor management. I saw an article on the internet last night about an interesting issue for a student health plan at Penn State University relative to United Healthcare and Optum. And it raises all sorts of issues and questions about all sorts of things. And bottom line with it is to have somebody on your team, even if they're external, who can advocate and try to sort through things from the perspective of the customer and their members is super important at times. And we play that role.
So there's a lot of moving pieces, but as you said, the pieces aren't moving at all. They're just sitting on a shelf. They don't provide any value. My question though is, does it need to be this complicated? It feels like healthcare is this black box that people just kind of know. It gives them medicine, it gives them care, but can there be more transparency in this?
Yeah, I don't know what the right answer to that question is, Bobby. I think it's the right question. And if the question is basically, does the system need to be this complicated? I think that three answers could be like number one, what system? Is healthcare really a system at all? Or is it a bunch of separate systems, loosely connected or poorly connected? In other words, the hospital system, how well is that connected to the insurance system? And how well is that connected to the pharmacy system and physical therapy? It really, I think could be viewed as problematic in a perspective of just all these different pieces that don't really talk all that well together. In fact, I was working and talking with friends at one health system about interoperability of the different IT systems across hospitals. And the one physician said to me, you think it's hard getting systems to talk across hospitals. Even in our own system, we're having a hard time getting our own systems to talk to one another.
Mm.
So another way to look at it, though, is it really shouldn't be this complicated. And I think that all of these problems should have solutions. And if you put good minds on them and you prioritize it and it became a priority within the system, all of this should be better than it is. But I think the final point I'd make is I think that part of the reason that it is so difficult is that I think that as a culture in the United States, we have like mismanaged expectations about healthcare in general.
Mm.
And what I mean by that is, let me give you an example. Like we, for example, do not want to wait. If our doctor prescribes an MRI or a CT scan, we want to be able to go and get that at a cost-effective rate quickly and have it be extremely accurate. But when you think about those things at the same time, well, we want to be able to go immediately, but the only way we can go immediately is if there's some sort of excess capacity that we could walk into. And excess capacity, in business school, we view it as synonymous with incremental cost. And yet we want the cost to be low. And we want it to only be efficient, but if you want it to be efficient, then the question becomes, well, then how do you tell people no?
Mm.
And we don't want to ever miss anything. But if there's a very small likelihood of a very bad outcome, and it's almost certainly not going to be picked up by a CT, but you send people for it anyway, again, you're driving cost up for the sake of, whether it's patient preference or risk management on the part of the provider who's worried about being sued for the near zero but non-zero likelihood of some rare diagnosis being revealed. So I feel like as long as we've got these mismatched expectations about how we manage cost, access, and quality in our system or systems, I think it's just going to be hard to really know how you prioritize effectively. It's like trade-offs.
Yeah, I'm hearing you say a couple things. One is it's not really one system. It's a lot of organisms or systems that are interacting with each other. And so maybe there's some problems or some assumptions that you make when you look at it as one whole system that you miss, that are actually out of touch with reality. And then kind of after that, it's, well, there's, checks and balances, or you're balancing priorities of, okay, well, yes, there's risk management, but there's also cost management. Certainly a lot of factors to consider when engaging with this topic. So let's maybe narrow the scope, because as you said, it's really hard to look at this holistically. Looking at the process of a doctor diagnosing somebody with osteoarthritis. I know you mentioned Apos. Can you explain what Apos does and how it helps with the problem of arthritis?
Yeah, for sure. So Apos is an Israeli biotech company that approached the problem of knee and lower back pain from a perspective that maybe there was a biomechanical solution to this issue that could influence something as fundamental as the way that we walk or our gait as a possible solution to the source of pain arising from knee problems, for example. And I'm not a physical therapist or a scientist in any fashion, right? My background's in consulting and finance and so forth in business. But spending a lot of time with physicians, physical therapists, and other clinicians in this, what I've come to understand is that by influencing the way that we walk through the use of this device, we're able to change the ground force reaction and the physics, creating the stresses on our knee, and train ourselves to not brace and compensate for these forces and this pain by actually making this our symptoms worse. And that there's some fairly remarkable results that have arisen from this device over the course of, roughly 6 months. We have people who were indicated for knee replacements opting to not get said knee replacements because they nearly immediately started seeing pain relief and improvement in their other symptoms. It's like a non-surgical alternative to a population otherwise indicated for fairly expensive surgery.
Okay, we see that there's a solution for this specific issue. Maybe how do we connect this to our bigger conversation of costs within healthcare?
Yeah, so I think that that's a really good question. And I guess what I'd share is that if I'm indicated for a total knee replacement, the things I'm primarily interested in are the quality of my surgeon, the quality of the facility where the surgery is happening, and the cost results to me, the implications of that. And how does that recovery and the impact clinically of that surgery look and feel to me? And what I would share with you is that it's relatively complicated to try to get answers to any of these questions. There are different sources of information about pricing, different sources of information about quality, and different ways that you can get information about what the outlook is for the results of a given surgery. And even with all of my background in training in this area of health insurance and healthcare, even for us, it's super complicated to try to parse all of this. One example of why is, for example, even there's something at every hospital called a charge master. And the charge master is kind of like the equivalent of a manufacturer's suggested retail price that nobody pays. And then what people actually pay is a function of whether they're paying cash, they're covered by Medicare, or some other insurance company, and they all have their own deals. So it makes it confusing. With that said, a lot of this is driven by Medicare, but to the extent that there are certain results that you get from surgery, the interesting thing about Apos is that it's a non-surgical alternative for people who are otherwise clinically indicated to be eligible for the surgery. It doesn't require that they be cut. It just requires that they be willing to use this device around their house for a prescribed amount of time in consultation with a physical therapist. And the consequence of it working is, from a lifestyle perspective, it really helps patients, right? It reduces their pain, improves their mobility, etc. And secondly, from an insurance and a healthcare finance system perspective, it's a small fraction of the cost of the bundle of care that's associated with surgery itself. So you would think that you should see, high rates of adoption as this becomes familiar to clinicians and the market, because it actually should improve results for patients and populations and reduce system cost. Does that make sense, Bobby, or is that what you were looking for?
Yeah, I think that makes a lot of sense. One of the things you mentioned I want to touch on, you said the charge master is kind of like the MSRP, that nobody actually pays that price. They pay some other negotiated price, essentially, that's factored in because of various ways that the payment is occurring. That sounds like buying a car. And in my experience, buying a car is a mess. It's stressful. It's complicated. It's like, I don't know that I necessarily want it to be like buying a gallon of milk, where the price is just whatever. But at the same time, going into a dealership, dealing with even a nice salesperson, is just a lot. There's just a lot going on. Is that what it's like dealing with the charge master?
it can feel like that. It really can. There's an interesting business model from this Norwegian business professor from some years ago that talked about business models as falling into three different camps. There was a camp that is more like a factory that's about producing widgets at efficient cost levels. There's a model that's it's more of an exploratory and investigative consultative. I think he called them solution shops. So like the third model would be what he called a network, where you have a business model based upon connecting different people and distributing information. An example of this would be like a telephone system. So when you think about healthcare and you think about the charge master, I think it fits pretty nicely into that MSRP factory sort of a model. Where if you're going in for a knee surgery, there's no harm in thinking about going into a factory and having an expectation that that surgeon in that place does a lot of knee surgeries and they know how to do them really well. But I think it would be a mistake to think about healthcare broadly that way, because think about your primary care physician. That sort of fits more into that solution shop model, right? They're consulting with you. They're trying to evaluate with uncertainty what's causing these symptoms based on your fact pattern. And it's a bit more iterative. When you get knee surgery, you don't want it to be iterative. And then finally, you could think about certain disease management programs and, for example, diabetes management services in that network kind of cohort, that there's sort of a different way to support the healthcare needs of a population of diabetics that, from a business model perspective, is in stark contrast to the knee surgery market, right? So anyway, yeah, I think that, but I think that for knee surgeries, connecting the price to a more traditional product environment makes a bit more sense.
Got it. Yeah. So kind of as we're wrapping up our conversation, as a recap, it seems like this conversation really shifts depending on how far in we zoom. Whether it's looking at the big picture and maybe it's actually multiple healthcare systems, and then zooming in on something like Apos, a specific technology designed to prevent or at least delay surgery for arthritis. And even within that device or that procedure or that patient's life, there's even different phases that maybe look like different business models. Certainly a lot to consider here, but I think this helps provide some frameworks in thinking about healthcare as a whole, moving forward and maybe even addressing some other challenges. I really thank you for your time today. Is there anything else you want to share? Any final words of wisdom?
No, I hope that your audience finds some value in this, and I would be curious to see a survey of results of your first question and how you reacted if anybody brought up the implication of stromboli or calzones into the pizza matter. But I'll follow up with you separately on Bobby and on that, and I'd be I'd be curious to take a look at some other people's responses.
All right, sounds good. Thank you so much.
Yeah, it's nice seeing you, Bobby. Thank you.
See you too. Bye. This isn't financial, legal, or medical advice, but we do discuss how we might invest our resources for a healthier society. If you'd like to learn more about today's topic and other public policy issues, check out the website, thejusticepodcast.com.